You didn't answer their phone.
In like 10 years, we'll have problems with Peripheral. If we had
Okay, so we are live at our ANMS Doctor-Patient Forum. We'll be starting in just a few minutes, so just hang tight with us, and we will get you to our event.
If I was creating a new Canada,
I'm like so not savvy on.
And I need to see you though, setting my fashion standard.
Actually, I think it's very simple.
You always look good. Every time I'm seeing you, you're dressed as not. You still?
The problem is like flip and cheese.
Hi, I'm sorry, I'm like sticking my trying to do Facebook Live here.
You want out here during the talks? Okay.
Yeah. I'm trying to get to the Facebook people to see the speaker.
You know what I mean?
I've never done this flyer. But it sounded like a good idea.
I mean, our foundation,
yeah, but it's about an hour and a half on
That's cool.
I think mine did start to spin.
Okay, everyone. So welcome to the Patient Doctor Forum, and thank you all for coming. My name is Dave Kahn. I'm one of the course organizers for the entire 3-day ANMS course. And what we're doing in the 3-day course, and the ANMS stands for the American Neurogastroenterology and Motility Society, is we're actually hosting a national course where around 500 people, mostly practitioners interested in GI motility, are here in New York City really to learn about challenging cases of GI motility and how to help those patients. So we are very excited to offer this part of the course, the Patient Doctor Forum. So first of all, thank you all for coming, on a Saturday in the summer in New York City. And so we have a lot of speakers today and a lot of interesting topics to present. I'm going to run through it very briefly. Each of the speakers have about 10 to 15 minutes, and we're going to try to stay on time. And please try to save your questions for the 15-minute period around 5:05, 5:10 that we'll have. So we're going to have speakers that will represent ANMS, represent some of our partners, and also represent patient support organizations for some of the conditions that patients suffer with GI motility disorders. All right, so our first speaker is Dr. Prakash Giawali, ANMS council member. He's professor of medicine at Washington University in St. Louis, and he's going to discuss the role of ANMS for patients.
Thank you, Abe, and good afternoon, everybody. Thank you so much for coming to this session. I'd like to start out by saying that everything we do has a relationship to improving lives of patients. So let me start by telling you what neurogastroenterology is, because the society is American Neurogastroenterology and Motility. So neurogastroenterology is the study of the interrelationships between the brain and the intestines, the gut, with relevance to understanding and management of GI motility and functional disorder. So what is motility? Motility pertains to movement of content in a hollow organ. There are lots of areas in the intestine that are hollow, where things have to move. So it's not just the intestine going all the way from the mouth to the other end, but also tubes that are around the gallbladder that take bile from the liver into the intestines. By extension, maybe even the pancreatic hollow tube. So some of us specialize in specific areas of this long hollow tube. My expertise is at the top end, it's the esophagus, the stomach, but in general, all of us are considered to be neurogastroenterologists. And then functional. The other term here is functional. Functional means that there are symptoms in the absence of disease as you would normally define disease on testing. So these are diseases or conditions that are associated with annoying symptoms. They're not really sinister. They're annoying symptoms that are troublesome and affect quality of life. But then the usual tests that are done to investigate each organ are generally negative. So it can lead to frustration, not only in patients, but also in the doctors, the physicians that treat these conditions, the initial doctors. The neurogastroenterologists hopefully are able to clear the air and set the management straight on a path towards recovery. Now, what about the brain? So the brain exerts control in the gut, but also receives inputs from the gut. And we have learned to recognize that the brain and its function is a very important part of neurogastroenterology and motility. So the society used to be called the American Motility Society. And as we learned more about the role of the brain, the name was changed to the American Neurogastroenterology Motility Society, established in 1980. It's dedicated to the study of neurogastroenterology. And the mission statement is to be the multidisciplinary society leading the field of neurogastroenterology. And there are many areas that the society focuses in: research, education, training, and patient care. If you want to know a sampling of diseases or symptoms in different organs that we relate to, we deal with, in the esophagus, obviously reflux disease, gastroesophageal reflux disease, or GERD, and then other disorders of movement like achalasia, people with difficulty swallowing, dysphagia, chest pain that does not have a cardiac cause. We're very, very careful about that because we don't want to deal with the heart. We're as good as your mother-in-law in treating heart disease because we're so specialized. So we leave that to the cardiologist. It's only after the cardiologists clear the patients that we deal with chest pains, non-cardiac chest pain. Then gastroparesis of normal movement in the stomach. Functional dyspepsia, conglomeration of symptoms in the top end of the intestine. And cyclic vomiting syndrome, you hear about this very interesting disorder that is a migrainoid disorder. It's like migraine, only patients throw up and have belly. And then in the small bowel, bloating and bacteria where there shouldn't be bacteria in the small intestine. Other movement disorders in the small intestine. Constipation, diarrhea. Everybody has heard about irritable bowel syndrome, relatively common condition. And then further down, issues with holding fecal material in, and issues with evacuating fecal material. So those are the disorders of the bowel. So within this broad disease spectrum, there is peripheral basic science and clinical disorders, diagnosis, and management. Basic science means the understanding of the mechanisms that relate to normal function as well as disease. And understanding of basic science is important in recognizing what is abnormal, why things are abnormal, and what to do about it. So we have a similar process at the brain end. So central relates to the brain. So brain-gut interactions. The understanding of pain, because in these instances, there is nothing to see on testing as a cause for pain, yet there is pain. The brain-gut axis is very interesting in that any kind of pain, indeed any kind of intestinal symptom, can be generated in the absence of an abnormality on a test. And that is very important for us to recognize and for us to teach patients, teach the families that these disorders are possible, these symptoms are possible in the absence of bad things happening, bad things visible in the test. Now we look at disease patterns, how frequent they are, the aspects of disease, psychosocial aspects, issues related to development, And then we also address diagnosis, management, treatment outcome, other kinds of tests that we do, both in practice, clinical practice, as well as within the realm of clinical trials, so studies to decide what works and what doesn't, and evaluation of new techniques of management. So the ANMS is passionate about advancing our field. And like I said, everything we do is eventually related to improving lives of patients who suffer from diseases that we are interested in. Currently, the ANMS has 6 areas of focus, and I'll go through each of these. The first is communication. This is an example of communication, patient-doctor forum. We have a social media presence now. You can see a computer over there that is doing Facebook Live, something I didn't know about. Apparently it works. Marketing. We have a journal, a medical journal, the Neurogastroenterology and Motility journal. We encourage our members to publish articles. There is also this focus on credentialing, so that doctors who treat these disorders are taught, but not just taught. We're trying to decide if we need to assess if they know enough, or if they have the right skills to interpret tests that pertain to neurogastroenterology and motility. We also make sure or work towards getting insurance companies and hospitals to accept some of the tests we do as part of reimbursement, so that patients can have access to some of these procedures. We have the ANMS Institute, which is part of our fundraising organization. The interested parties and corporations, pharmaceutical companies may choose to work through the ANMS Institute, because resources are always worthwhile and are needed in furthering our approach. We sponsor meetings. The ANMS is an American society, but we are part of a broader world society, the Federation of Neurogastroenterology and Motility. And every 2 years we have a meeting of the entire body from all around the world. So there's a European group, there's an Asian group, an Australian group, and we all get together, try not to fight, but we all get together and talk about diseases that affect gut in this fashion. We do these postgraduate courses. We encourage young investigators, select a few, and bring them over to our meetings so that they can be mentored. We have a focus on research. Some of the money that is raised and some of the revenues from some of our activities go towards these clinical and basic research grants and towards mentoring and support. And finally, education. So we try to encourage people to enter our field. And to do so, we have now taken up this process of defining what it is that we need to teach our trainees and what tools do we need to ensure that they are taught properly. We have 9 centers of excellence in the country. And so trainees can choose or can apply to go to one of these centers and spend some time with a neurogastroenterologist who has expertise in the area that the trainee is interested in. And this is again a program that is supported by the ANMS. The ANMS also has worked towards providing these pocket cards and pocket guides on common conditions. This is more directed towards physicians who may have an interest or may have a clientele of patients with these disorders. We also have brochures that are targeted towards patients, both in terms of symptoms and diseases, as well as in terms of tests that we do, so that these tests are explained, the process of the test, the indications, the risks, and what is generally expected out of these tests. So all these brochures are available through the Motility Society website listed there. And then we partner with different support groups. You'll be hearing from some of these support groups, the Cyclic Vomiting Syndrome Association, the GPACT, the IBS Self-Help and Support Group. And there are a couple others here. There's also a gastroparesis research study that patients with this disorder can participate in through the Motility Society website. So everything we do, every single thing that the ANMS does has a link to patient care, improving the lives of patients. Thank you very much.
Thank you very much, Dr. Giovanni. So remember, you're going to have plenty of time to ask questions, after we're done with all the speakers, and we're going to have 6 total speakers, and we'll have about 15 minutes for questions, okay? So our next speaker is going to be Dr. Frank Hamilton, who he just walked outside. So when he comes back in, he will update us from the NIH on support for digestive diseases research.
So if somebody has a burning question, I can answer.
Yeah.
Anybody has a question?
There it is.
Doctor, you mentioned 9 centers of excellence the ANMS supports. One of them on the map. Is there one in New York? It appeared from the map currently, or near New York at this point?
Philadelphia.
So Temple University in Philly. Thank you.
Okay, so Dr. Hamilton will talk to us about an update from the NIH on support for digestive diseases research. The last one.
Yeah, I don't know if we'll be able to see it. Oh, it's not. Yeah. I think it's the last one.
I see Jamie Hamilton up here. But okay, I just want to first of all thank the ANMS for inviting me to be a part of this very important endeavor, because it really underscores the importance of why I'm here and what I do every day. How many of you pay income tax? So if you really think about it, this is your NIH, and I just want you to realize that your involvement in what we do here really goes back to you, the consumer, because our mission is really to improve the health of the United States. What happens is so often that most people think, well, the government has so much money, but really our efforts over the last 20 years have really been dramatic. When I first came to NIH and worked in this area of irritable bowel syndrome, which I was very much a proponent of, I'm a gastroenterologist by training, and I sort of shifted my career from going from being sort of a clinician and then eventually went into administration. And when I first came to NIH, I was the only gastroenterologist in the department in our division, and most of the people in our division were PhD scientists. And Dr. Bilgo, who was at UCLA, came to me and said, would you come here because we need a gastroenterologist? And back then, at that time, if you said irritable bowel syndrome, most people would say, oh, it's all in your head. And I have been so impressed with the change and the scientific advances that have been made in this area. And that's due to the support of people in this room who have made that special effort to make a difference, and not only for themselves, but for family members. And that's why I'm very much committed, and I'm very proud that ANMS asked us to be a part of this meeting, because we have to be partners in really improving the health of patients, as Dr. Khan and all the other researchers have done and presented at this meeting. It's up to us to make the difference. If we don't care, nobody else will. And I just want to mention that our budget is currently $1.8 billion dedicated to digestive disease research. And when you look at the entire picture, you say, well, that's not very much. But considering our current budget is $33 billion per year. And one thing that's very unique about our institute is that our division is committed to really improving the health of the country. But we always tell young investigators that there are other areas at the NIH that do GI research or digestive disease research, which includes the office of our director, the National Cancer Institute, the National Institute of Allergy and Infectious Disease, the Child Health Institute, the Institute on Alcohol Abuse, as well as the Aging Institute. And when we talked about our division, which is responsible for really supporting basic translational research It's from the bench to the bedside is our motto. And we really want to emphasize is that we want to look very carefully at the not only conditions of the GI tract, the esophagus, stomach, bowel, duodenum, liver as well. And it is critically important that we take a broader perspective. One thing that we really have emphasized over the last 20 years in our division is the change in the dynamics in our country. When you look at the maps of our country, the epidemic of obesity is just massive in this country. So through the direction or the efforts of the Congress, we have devoted more research in this area because it impacts on so many different diseases, especially those in motility as well. And I don't have to preach to the choir today, but you say, why are these diseases important? And you will look, when you look at the number of people in this country who are affected by gastrointestinal disorders, if you look at some of the prevalence data, at some point in life, 60 to 70% of us somehow are affected, whether it's a diarrheal case or eating something at a restaurant that was not very clean. But when you look at the major impact that these gastrointestinal diseases have on our community, it's massive. And the other thing that you really have to take a look at is how much is this costing the government? And one thing that so often we look at some of the data that came from the CDC several years ago, and the data that I'm presenting is somewhat a lag phase. It says 2006, but when you do government data, it's almost every 10 years that they make these phenomenal figures about how much the cost of a disease is. But when you look at the amount of money that is affected by, we're spending about $142 billion per year on GI disorders. That's both direct and indirect costs. And when you look at the number of patients who are hospitalized for gastrointestinal disorders, it's astounding, about 262,000 per year. And then there are some people who say there's some deaths that are related, but there's a question how valid this true estimate is. But it's really an impactful disease on so many people in our country. And when you look at the care of patients in this country, it's not just the individual that suffers, but it's the families also. A lot of parents will lose time, especially, for example, young kids who suffer with functional constipation or irritable bowel syndrome. The parents lose time from work, so it impacts the entire family. It's a family disease. And again, I just really want to stress is that our institute finally sort of got the message that, functional bowel is important because it impacts so many people. And it's really sort of like the coming out of the closet, they would say. But what happened is so often, I was sharing earlier with one of our other speakers about several years ago, and I can tell this because Senator Kennedy is dead, but one of his staffers came to us and he said, I'm just suffering. So through the efforts of the staffer at Senator Kennedy's office, legislation was put in place that says we got to do something about this condition and to bring awareness about what we need to do in this country. And what happens so frequently is that you have one person who's a silent voice in the desert who makes that effort to push your congressman saying, there are a lot of people in our community suffering. We have to do something. And what happens is that we'll get congressional language that says NIH should have to do something about these conditions. And then things start happening. So don't be afraid to be the voice in the desert, because without your help and support, we can never achieve some of the things that we've done over the several years. I just wanted some of the other things that we really encourage is to encourage investigator-initiated awards to a lot of people. We really have made an effort over the last 15 years to do more clinical trials in the setting of irritable bowel syndrome. We have a program that's about ready to complete. It's looking at kind of cognitive behavioral therapy in the setting of IBS. And this took almost 9 years to really sort of nurture and really finally get this study going. And initially, when it first came to the NIH, it was looked upon and said, why are we going to be doing this? And if some of you may or may not know, there are many patients who suffer with IBS. And so often their doctors will say, oh, it's just all in your head, and not realizing that these people are suffering. And one of our researchers at the University of Buffalo decided to work with investigators at Northwestern looking at this approach to IBS, cognitive behavioral therapy in the setting of IBS. And it's remarkable how patients have done with this modality. And that's due to the efforts of several organizations. The other thing that we have are called research centers throughout the country. One other thing that we have really sort of encouraged the pipeline, and we heard the ANMS council members speak about our need for really encouraging young investigators to pursue this area of research. We have special programs such as our training programs, which are earmarked to really train young investigators to pursue the field of motility disorders and dysfunction. 20 years ago, and it's very interesting, I spoke to one of our attendees at this meeting, and he said, I'm coming from Philadelphia to New York City. And I said, you've been in Philadelphia for the last 25 years of your career. And he said, guess what? New York City is a wasteland. There's nobody in New York City who's focused on doing motility disorders. And it's true. And that's what we want to do, is encourage people to get involved, encourage young people. I was involved in a workshop for young investigators on Thursday, telling them that there are opportunities here because there's so many interactions with other diseases, which we'll hear about later on today. The other thing I just want to stress to you is why we support this, because this is such a vital area. There are areas that we're looking at some of the opportunities that we see with multiple sclerosis and Parkinson's disease, how these patients have unfortunately been sort of pigeonholed. It's just a neurologic disorder. And so often people don't realize that their quality of life has been impacted. Some of these patients with MS and as well as Parkinson's will suffer from esophageal reflux disease. The neurologist won't even know anything about it. He just says, I'm just focusing on your motor disorder. So I think it's critically important that we sort of integrate, and that's what my focus at NIH now is, to really sort of integrate and have us do cross-talk with other disciplines so we can really move the field forward and eventually improve the care of our patients who really suffer in this country. I want to just, there's an effort by the Office of the Director at the NIH, really, and really sort of taking different approaches. This is a program which is called our Stimulating Peripheral Action to Relieve Conditions. This is called our SPARK program. And this is a program that through the congressional mandate, asking investigators to look at different tools, how we can address things that may affect the periphery other than looking at the brain only. So this is an effort that we're encouraging all our young investigators to take advantage of. The other thing is that we had tried to build partnerships with many of our advocacy groups, and I would be remiss and not say that I'm really indebted to the people like the International Foundation for Gastrointestinal Diseases and also GPAC. In 2003, we met in Orlando, Florida at the Digestive Disease Week, and we had a lot of patient advocates saying, what is NIH doing about gastroparesis? At that time, there was nothing in our research portfolio, and through their efforts, in 2006, we were able to fund, and we've been able to fund for the last 16 years, a gastroparesis consortium in the amount of over $30 million. And that's through the efforts and their partnership because of their advocacy. The other one I want to mention is the International Foundation for Functional Gastrointestinal Disorders. They have been partners with us since 1992. We had our first meeting in Washington, and at that time, there was very little in our portfolio that we were actively endorsing or embracing. Through their efforts, we've been very effective in having fecal incontinence workshops, bowel awareness workshops. We've increased our patient advocacy, or I should say our patient clearinghouse on different diseases within the GI tract that impact so many of our patients. So we're indebted to the efforts and the partnerships that the patient advocacy groups have developed with the NIH over the years, and we're indebted for really, it is an unselfish part on their part to really sort of move ahead and make it a difference. The other thing, what I'd like to encourage all of you to do is take advantage of our health information page. The NIDDK is committed, as the ANMS is about education of the public. We have a public responsibility to provide our public with valid, scientific, well-researched, evidence-based medicine on our website. So often, and as most of you know, if you go to the website, there's so much on there, and the validity of some of the information that's out there, we're not sure about the scientific validity of it. So I would encourage you to tell your patients, take advantage of these websites. All our information is all peer reviewed, and we make every concerted effort to make sure that everything that is printed is scientifically correct. So we really take great pride in really providing you with a valid patient information. And these are free to the public, so take advantage of it. Although our institute has many different missions related to diabetes, digestive, kidney, our institute is very committed to our foremost mission is improving the health of America. And we can't do it without you. We're indebted to all of you that are here today. We want you to take advantage of advocacy. If you don't get out there and act up, expression from the 1980s and 90s, our patients will suffer. And the advances that we make are due to your advocacy, going out, talking to your congressman, telling them about the importance of this disease. So I'm going to ask you to make a commitment, not only to me, but to all of the people that are in this room, that you'll make the commitment to get out and make a difference and talk to your congressperson. Elections are coming up in 2018, so they depend upon you. So in order to really make a difference, we depend upon you to make the difference in patient care in this country. So thank you very much.
Okay, excellent. Thank you very much. So our next speaker is Dr. Jamie Hamilton from the Michael J. Fox Foundation. He's going to really be discussing how the foundation relates to functional GI and GI motility disorders.
So while I'm getting set up, it really is a pleasure to speak with you all today. And in a little bit of a different realm in that I am speaking on behalf of the Michael J. Fox Foundation, which is really an organization that's focused on finding a cure for PD. And also, I have to say, full disclosure, it is an honor to be presenting beside my father, Dr. Frank Hamilton. So it really is quite a pleasure today. So, if you're interested in the family history of Hamilton. But no, it really is a pleasure to be speaking with you all today, and I'm really pleased to be speaking about one of the few organizations in New York City that is dedicated to not only PD, but understanding other symptoms other than purely motor symptoms in a PD subset. So how many individuals know somebody who has Parkinson's disease? Quite a few, and I'm glad to see you guys here. Or a family friend. And so we understand that when Parkinson's disease was first characterized, it was in 1817 by James Parkinson. And at the time, we really thought it was purely a motor disorder that was really resulting from cell death in the brain. There's a specific area in the brain called the substantia nigra, and that area actually releases dopamine cells, which are really responsible for coordinated movement and directed movement. Today, we know that disease is really far more complex than just purely a motor symptom. And we know that individuals in the PD community can experience a range of motor and non-motor symptoms. And some of these symptoms can really be more troublesome than others, particularly GI symptoms such as constipation and even gastroparesis. Unfortunately, only current treatments currently that exist really just address the motor symptoms themselves. And none of the medications that are currently out on the market really stop or slow the progression of the disease. And so the foundation spends a considerable effort not only to accelerate the development of improved therapies, but ultimately find a cure. We are one of the largest nonprofit funders of research, and it was really founded from the patient perspective by actor Michael J. Fox in 2000. And since the inception of the foundation, we have funded over $700 million in research, and we have 550 active grants currently in our portfolio. So we really pride ourselves on a business model of efficiency, urgency, and accountability. One of the great things that Michael J. Fox always says to us as staff members is that we don't want to be in existence in 20 years. We want to find a cure. And so our dedication to that cause is really driven by a lot of the efforts in terms of raising new dollars annually, which are quickly deployed to awardees that are doing novel research. We periodically check in with awardees because we really see it as a partnership. It's a collaboration. We're working together towards not only speeding therapeutic development, but also finding a cure for the disease. So if funds are not spent appropriately, we will pool those funds so that they can be deployed to novel new research. And we pride ourselves on that, as we have a scientific team of research PhDs as well as MDs who really help us to oversee the scientific merit of the research that's being done. We do not function on an endowment. So every 89 cents of the dollar that we raise is spent towards research. So we really see our priorities as really not only focused on altering the course of the disease, but really defining what PD is, what things can actually improve our understanding of PD in terms of onset, risk, and even the progression of the disease. And as you can see, we have a number of insights, both in terms of motor and non-motor symptoms, some of which are more disturbing than others, as well as understanding genetic contributions that may change the course of the disease. And we know that we have a very diverse PD community that has different manifestations of symptoms. Some people have more motor symptoms or more cognitive symptoms. And so if we can understand more about the PD biology, we can actually really have more targeted therapeutic efforts in terms of development of drugs and making sure that individuals can have an improved sense of quality of life. Because unfortunately, there is no cure for Parkinson's. But we prioritize pursue these areas, providing financial and intellectual support for projects from discovery through the clinic to make sure that progress is made towards these new therapies. And so when we think about PD in the context of GI disturbances, we kind of see that as a motor, but it's also a non-motor symptom, right? Because for such a long time, historically, neurologists really weren't aware that there were other symptoms. They were poorly focused and really centrally focused on just treating motor symptoms. But if you think about motility, that is a form of motion, right? And it does impact your quality of life overall. And so we kind of see GI kind of falling into two bins of symptomatic symptoms as well as what we call a field-wide challenge. So we know in other disease states, for example, diabetes, we know that blood sugar levels is an indicator of the presence of diabetes. And in cholesterol, we also know that the indicator of the levels of LDL and HDL can inform us about our cholesterol and our cholesterol risk. Unfortunately, in PD, we don't have that clear indicator of disease, right? And a lot of the times after an individual unfortunately passes away, it's not until we actually do an autopsy that we realize that there's actually PD-related pathology in the brain. So if we can target and focus efforts in finding and identifying a novel biomarker, is what we usually call it in research, that can really inform us about therapeutic developments, creating new compounds in the field that can address not only motor symptoms, but also non-motor symptoms. So to just give you a kind of a snapshot or kind of a flavor of some of the initiatives that we're currently interested in, we are looking at a number of leads across different leads in our body, biology, and understanding how this link between PD biology and symptoms can really inform us about the disease itself. And we do have a number of projects that are targeted towards understanding GI motility, gastroparesis, which was what just discussed earlier. And then we also want to understand how that some people may not respond very well to the current motor treatments that are out there. And right now, the gold standard is levodopa. And some people are not able to absorb the medication, so it's not as effective as is somebody who may not have those GI disturbances present. We also know that innovation really amplifies our impact in the field, and there's one that I just want to really quickly highlight is our Fox Trial Finder tool. And we kind of call this the Match.com of PD research because we match individuals and patients with Parkinson's with clinical trial research in their area. So we encourage you, if you have time today or over the course of the next couple of weeks, to please visit foxtrialfinder.org, which you can fill out a profile. It takes less than maybe 5-10 minutes, depending upon what medications you're taking, and it'll tell you what clinical trials are in your research area. And that has really improved the way in which enrollment and people actually retain and complete the research studies. And then also has a huge impact on how quickly actually drugs get to market. Lastly, for anybody who's interested in submitting a research project, we are very interested in understanding these biomarkers and hopefully finding novel things that can inform us about PD as well as PD progression. So I encourage you, we have a special call out for inflammation and mitochondrial biomarkers, which is basically the batteries of the cells, right? And as we get older, those things die off, but we really want to understand in PD why that happens. And is there a certain pattern of progression that may be different in different patients? And so we're very interested in supporting research in this particular area. So with that said, thank you so much.
Thank you.
Thank you very much. So now we're going to have 3 consecutive patient support organization presentations. So our first, Cecile Rooker will present from the International Foundation for Functional Gastrointestinal Disorders.
Thank you. My name is Cecile Rooker, and I'm the Executive Director for the International Foundation for Functional GI Disorders, or IFFGD. I want to start out by thanking the ANMS for hosting this forum, which is really important for patients to be able to hear some of the resources and things that are going on in the community that directly affect their ability to cope with their illness. And I want to just spend a few minutes letting you know what IFFGD offers to the patient community as well as to the academic community as well. The International Foundation for Functional GI Disorders was founded in 1991 by Nancy and Bill Norton. Nancy is actually a patient with a functional GI disorders. This was formed around her kitchen table due to a need that she felt, and I'm sure all of you feel as well, to have more education, more awareness, and more research in the area of functional GI motility disorders. From the very beginning, the Nortons set out with three main goals, and that is for informing the public, Washington, and all parties involved about these disorders, assisting the patients themselves in dealing with their disease state, and also supporting all areas of functional GI, research, education, advocacy, awareness, the whole gamut. The ways that IFFGD tries to help patients in this particular disease state is through support, education, awareness, advocacy, and research. Providing the community of support for the patients. So many of these patients feel that they're the only one, or they're one of very few. What they don't realize is there's actually an entire community of people in this world that suffer from GI illnesses of all types. It is our hope that we will be able to provide a community where these people can engage with each other. On our website, we offer a community where they can share their personal stories, support one another, offer comfort, maybe even some advice of how they cope themselves. We also have active social media with Facebook and Twitter, which allows patients to be able to communicate with one another, raising awareness around the disease state. And for those that just need someone to talk to, or you need some specific information, you don't know where to find it, we do have a call center, and you can find that information on our website. Education, that is one of the building blocks of IFFGD, one of the things that we're completely committed to, and due to the help of some really wonderful research and academicians in this area, we're able to provide an entire toolkit of educational resources for patients. First of all, we have 8 different websites, many disease-specific state websites that you can find information about your disease. We also have brochures and fact sheets, over 300, written by the researchers, the clinicians, the people, the experts in this field. There's over 300 of them. They're available online. We have them in print, and many of your doctors may have them in their offices, and we provide those to you. Please check out our research educational products. You can download them for free, and there's a lot out there for you. We also have provided reporters' guides, and that is an effort by IFFGD to make the media more educated as they report on our disease states so that they can provide accurate information to the public. We have a monthly e-newsletter, and you can sign up for that on our website. Monthly, we try to report on the latest research activities as well as any awareness events that may be happening. And that goes out every month online. And of course, as I mentioned, we have a very active social media platform. Raising awareness. 20 years ago, people were afraid to speak about their GI illnesses in their home, much less out in the community. But as Frank Hamilton has told us, that's changed a lot. And due to efforts of Senator Kennedy Staffer, as well as many individuals, physicians and clinicians, we are raising awareness about functional GI motility disorders. We're trying to dispel those myths, those ideas that people have that are not true about this very misunderstood set of diseases. Using awareness to the public, we are able to mobilize our advocacy efforts, which I'll mention in a minute, but also encourage research to the young investigators, like ANMS is working so hard to do as well, and to help improve the patient's experience, their families, and how they deal with their illness. IFFGD has many ways that they are trying to raise awareness. One of the ways that they have, we've been very successful is by getting 3 particular items on the U.S. Health Observances calendar. We support IBS Awareness Month, which is in April, Gastroparesis Awareness Month, which is August, this month, and also GERD Awareness Week, which is the week before Thanksgiving every year. And for obvious reasons. So we promote these, we've been able to get these on the official U.S. observance calendar, and we promote these awareness months and week through advocacy efforts, educational press releases, media coverage, and also through our social media campaign. Advocacy is very important. As Frank encouraged you to be the voice in the desert, IFFGD has worked very hard to try to help mobilize all of these voices in the desert, bring us together. We've had a presence in Washington for many years, and we are advocating on behalf of the patient for more research funding, for better access to care, and more availability of better treatment options for patients. One of the ways that we're taking action and trying to get this into legislation is by promoting and sponsoring the Functional Gastrointestinal and Motility Disorders Research Enhancement Act. Is currently in the House as HR 1187. IFFGD works very hard to promote this Research Enhancement Act, which will hopefully provide centers of excellence, additional research funding, and better outcomes for patients. We sponsor a National Advocacy Day. This year in 2017, it'll be September 12th. We encourage all of you to participate in our Advocacy Day, where IFFGD comes together with patients around the nation on one day by creating many small voices in the desert to create one big loud room in Washington on September 12th, and let them understand that we have a very large patient community with huge unmet needs. If you'd like to get involved in our Advocacy Day this year, please contact us. In addition to those items, IFFGD has been called upon and has been able to give testimony to FDA, to the VA on behalf of patients, to NIH. We've participated in different panels and boards in Washington to try to help enhance the patient experience, advocate on behalf of the patient. We are also a member of the Digestive Disease National Coalition, which is a group of about 50 interested parties that together stand in Washington to advocate on your behalf. Research, however, is probably the biggest need, right? We all need more research. We need better treatments. We need better outcomes. We need better options for our patients. IFFGD has been committed to being a part of this research. We advocate for more funds in Washington. We also award research awards and grants, and we also have an international symposium biannually to educate physicians worldwide and have them a place where they can come together and learn from one another. Another thing that IFFGD is extremely committed to is the patient voice, making sure that everyone understands the deep pain and suffering that these patients have, the needs of the patient, and also understanding better what the patient's understanding is of their disease. In the past, we've had 4 different surveys that we've initiated. 2 on IBS in the real world, IBS patients, their illness experience and unmet needs. In 2010, we did managing incontinence for those with fecal incontinence. And just recently, last year, we had a survey on gastroparesis in the community, which was just recently published by Henry Parkman. Not only do we have these surveys and support research ourselves, we also promote education around clinical trials. We do have on our website the available clinical trials in functional GI and motility disorders, and are able to assist patients in, just as the Michael J. Fox is doing for Parkinson's, IFFGD is trying to do that for the functional GI motility disorder community as well. That is available on our website. Moving forward, IFFGD is looking to continue our collaboration with Washington, also with other organizations like the ANMS, and engage one another to partner together and collaborate and to try to ultimately make this world that we navigate in as patients with functional GI motility disorders a better place.
Okay. Great, thank you very much. So we have two more patient support organization presentations. So the next one will be presented by Dr. Tangam Venkatesan from the Cyclic Vomiting Syndrome Association. She is professor of medicine at Medical College of Wisconsin.
I always know I'm up next when somebody hesitates over my
And I practice that.
Well, thank you for the opportunity. I'm actually representing the Cyclic Vomiting Syndrome Association. I don't know if any of you have heard about this condition at all. Well, it is actually a very debilitating condition where patients have frequent episodes of nausea and vomiting. And again, this is a small organization. It is a nonprofit that was actually established in 1993 in Milwaukee by somebody by name Kathleen Adams. You can actually see her in that picture along with her daughter, and I think that's a hamster maybe. And really her story is very remarkable. Her daughter developed CVS when she was about, say, 3 or 4. She would vomit violently every month, and she would be taken to the hospital. Nobody knew what was wrong with her. This went on for 10 years. And then finally, she met a pediatric gastroenterologist, and she's very persuasive. And so she finally convinced a doctor by name Dr. Bill Lee, who's sort of really the father of CVS, to start studying this disorder. And that's how the CVSA was founded. And fast forward now, there was a time when even physicians didn't know what it was. And now, thanks to the ANMS and other organizations, we have frequent presentations, and I had the honor of presenting on CVS yesterday. And really, it's grown into a huge network. We have a lot of people from Canada who join us, and also the UK. We serve several countries worldwide. There are people who call us from Egypt. There was once a call I got from a nurse practitioner, and I was trying to give her some advice about a patient. And then I said, well, do you think he could come here? And then she laughed. So I said, well, why not? And she says, well, I'm in Alaska and I need to go dog mushing to give this guy IV fluids, real story. So I just backed off and I just gave her a plan. We have almost 40 medical advisors. And really, again, Kathleen, this is the structure of who we are. And Kathleen Adams, like I said, is the founder. And the president, we have Debbie Conklin, who is the director, and she runs it. This is actually Debbie's parents, and they just sort of retired last year, but they used to run it before Debbie. And we have several board members and obviously volunteers. And, my colleagues are not going to see these pictures. They look like mug shots of them. I had to do it in the last minute. But these really are very, several important people. And, this gentleman here, his name is David Fleischer. He was the one who actually diagnosed Molly with CVS. He's retired now. I think he deserves to be retired. And he really worked tirelessly, sort of the grandfather of CVS. And then Bill Lee there is on the right. That's myself. That's the only picture I could find. And then we also have a psychologist and a PhD. So we have several. We are all the chief medical advisors, but there are also other doctors who work with us. This actually is, again, CVS, people thought it's generally something that afflicts the destitute and the desperate. But we have a few celebrities. So Chandra Wilson, she's actually a fantastic person. And her daughter has CVS, and she got involved with our society a few years ago. She actually came to Milwaukee. And so she really does a lot of work for us. And before she came to Milwaukee, I've never seen Grey's Anatomy, So I was, and the day before I met her, I said I better see at least 2 episodes so that I need to speak intelligently about Grey's Anatomy to her. But she's, like I said, she's a fantastic person and does a lot of work for the CBSA. And again, we also have an organization actually in Japan. That young man's name is Shun. He had CVS as a child. He's visited us several times, and he actually visits the NORD. It's an organization for rare diseases. And so we're really growing. We do a lot of things. So we raise awareness about CVS through education. And then we obviously, the CVSA provides support for families. There's somebody, you can get a real person on the telephone who give you real advice. They connect, physicians and patients and, sort of try to get plans like this person in Alaska with the dog mushing. And we do have an international family conference. And so it's actually a more informal session where we get speakers from all over. And that's been very valuable to really patients and their families. And finally, the CVSA also promotes research, promotes research in CVS. And one of the other things is we also collaborate with multiple organizations, and I'm happy to say that the ANMS and the CVSA have recently collaborated. And for the first time, we are developing guidelines in the management of adult CVS, and hopefully, we'll have that out next year. So really eagerly awaiting that. That's an example of how, one of the examples of how we collaborate. And again, they have a website, and there's a lot of information on that website. So if you know anybody who has CVS or you have CVS, please feel free to visit this website. And there are a lot of resources. There's good information. Like I said, you get all sorts of things on the internet. And like Dr. Hamilton was saying, it's very important to go to the right website to get accurate information. And so you can certainly avail of our website for that. We have updated references, we have articles, we have newsletters that come out. And then we have a CVS Facebook page, and then we also have a message board. So there are multiple things that you can really avail of. And then how can you be engaged? I think really this is really a two-way street. There are multiple partners in this entire process. So I don't think physicians or even societies can achieve anything unless we all come together as a unit. And that's what makes us strong. So be engaged, be aware. If you want to become a member, please do so. Obviously, there are a lot of fundraising efforts that you can be involved in, and importantly, participation in studies, because sometimes physicians or researchers struggle because maybe patients feel better and they don't want to really participate. But that's really important, because only by doing that can we understand these disorders better, and only if we do that can we develop better therapies for all of these disorders. And then there's actually our 13th International Adult and Family Conference for next year. That's going to take place in Milwaukee, so please save the date or pass it on if you know anybody who has CVS. And finally, this is just a picture at Digestive Diseases Week, which is a huge really gathering of gastroenterologists. There are about 15,000, I think, or 10,000 of us who take over a city. But anyway, that's just a picture of us at the CVSA booth. So thank you.
Great. So our last patient support organization will be the Gastroparesis Patient Association for Cures and Treatments, or GPACT, to be presented by Carissa Haston and Michael Smith. And then after this section, we'll go straight to the question and answer, session, and I'll ask all 6 speakers to really join me up here, or 7 speakers actually. We'll try to get an extra chair.
I'm Carissa Haston, and this is Michael Smith. I'm the president of GPACT, and he's the vice president. And just talk about GPACT. We are a 501c3 nonprofit founded on August 23rd, 2001 to fight gastroparesis, colonic inertia, and chronic intestinal pseudo-obstruction, and other paralytic conditions of the digestive tract. And we run on a fully volunteer basis. Most of our volunteers are patients, so we completely understand the conditions, and that helps us with our programs, figuring out what we want to do. 100% of all the proceeds that we get go back to the community, and we're not paid at all, so everything that we receive goes back into the community. And we have a medical advisory board consisting of the top five of the top leading DTP, digestive tract paralysis physicians in the country. We're members of the DVNC and the ANMS, and we work on a collaborative basis with a number of other nonprofits and businesses to help provide resources to patients to meet the various needs within the population. So whether you have pick line, tube feedings, whatever, we work with a whole bunch of organizations to provide for those needs. So, and we were founded by a handful of patients who were met together in the largest online support group, Yahoo group, which I started back in 2000 and 2001. We had so many patients, we realized the need for a nonprofit for it. So we came out and formed GPACT out of that, because we recognized the need for the lack of awareness and that there were a lack of resources available to patients. Our end goal was to find a cure, but we knew that in the process of finding a cure, it was going to take a really long time. So we wanted to provide resources that could help patients cope now and get through the challenging times right now. So we have a lot of programs that deal with that, which I'll talk about later too. We've become a leading organization fighting digestive tract paralysis internationally, and we reach out to patients in all 50 states and over 60 different countries through social media, our website, attending conferences, and through our printed work. And our Facebook page alone has over 14,000 followers.
We're going to take on a tag team approach here. What are the conditions of digestive tract paralysis? Well, I mean, in reality, GPACT was formed nearly 17 years ago at the beginning of the millennium, really to encompass the fact that there was a need for greater support for the conditions of digestive tract paralysis. If you think of motility disease as a broad spectrum of disorders, starting on the one end with irritable bowel syndrome and fecal incontinence, to the other end with gastroparesis, paralysis of the stomach, or severe weakness of the stomach, chronic intestinal pseudo-obstruction, which essentially could be a spastic or flaccid paralysis of the entire digestive tract and all the involuntary muscles from the esophagus down to the anus, and colonic inertia, which results in a paralysis of the colon at this point. And really the inspiration for these efforts, twofold. Carissa, who has been a remarkable advocate and a hero in this area, who had pseudo-obstruction and survived a 5-organ transplant, essentially, to regain some of her function in her digestive tract. And one of our other hallmarks, one of our medical advisors, who I believe is sitting in the back, Dr. Ken Cook, although in New York we would call it, say, Koch here, but no, it's definitely Cook. And Ken, and we'll talk about that more later, Ken has really been an inspiration in both the art and the science of medicine here. I myself have had intestinal pseudo-obstruction for 30 years, and one of my inspirations for the fight in the late 1980s, I was treated in Brochures Hospital out in Long Island, and I was actually one of the first cases that they had ever seen at this point. And here, thanks to the work of Dr. Cook, and we'll mention a few others afterwards. And the term digestive tract paralysis is meant to encompass. We have a number of patients who, if you're familiar with the term differential diagnosis, who perhaps start out with a diagnosis of irritable bowel syndrome or something else along those lines, go through a lot of the necessary treatment protocols for IBS and some of those lines, and find either no improvement or find their conditions still deteriorating. Unfortunately, in my own case, with regard to pseudo-obstruction, a 5-year surgery eventually led to a failure of my gallbladder and the finding that I had a myopathy, which is either a scarring or a destruction of the muscle cells of the digestive tract, and a neuropathy, which is a blunting of the neurons of the gut, and as Ken Cook would describe. We also deal with disorders that affect pacemaker cells or the interstitial cells of Cajal, which communicate and tell the nerve and muscle cells what to do throughout the digestive tract. And the real hallmark is the gut, much like the heart, is a smooth muscle organ, basically has its own electrical rhythm, and normal peristalsis is generated by a 3-cycle per minute complex, which in people with no disorder helps to allow for digesting food and sleeping the contents. That complex really has disappeared in our patients, both children and adults here at this point. And as our fight is both to improve the nerve and muscle function in order to get that back up and rolling again here at this point. I just give Carissa an opportunity to talk about some of the services that we provide.
So the services we provide, I was diagnosed in 1994 before there was the internet or anything like that at all, are very much available. So I kind of realized a lot of the things that we needed. So we provide a toll-free PAL line for patients to call and ask questions and talk to somebody in person that can has the conditions. These people are experienced, they've had it a really long time, and they're very caring, and they'll take phone calls anytime. So that is one thing that I really would benefit from. We also provide free accessibility cards, and some of these are actually, one of these was actually a suggestion that a patient made to us, and we said, yeah, that's actually a really good idea. So we provide restaurant cards, which the restaurants are not legally required to take, but it does validate and it does help to ask for a discount on their meals. Also, restroom cards to be able to get into restrooms more quickly, or an employee restroom, and venue cards so patients can take in food or whatever to movie theaters or places that might not allow it if they have special needs to eat. And also backpack cards for people who are on, this is the one that was suggested by a patient, for people who are on TPN or 2 feeds, and sometimes there's places that don't like you to carry a backpack in, and this just verifies that they need that backpack with their 2 feedings and TPN. And then also we provide a lot of educational information, like booklets. We have a 16-page booklet and flyers, and we provide all this for free. And the numerous support groups focus on the various demographics and needs. So we reach out to teens and kids and caregivers and general group and all that. We have a Send a Smile program, which is where we send out a package of care gifts to about several patients every month. We receive the care gift from us. These patients that we recognize in our community that are struggling. And we also have some cookbooks that have been written by patients. They've sent in recipes and said that they tolerated them really well. And we have a dietitian evaluate the nutritional value of each. And so that can be ordered on our website. And that has helped a lot of people figure out their diet, because it's difficult sometimes to figure out what to eat when the doctors don't, they just give you a basic guideline. So, and we also have the first IRB approved international registry into gastroparesis, which she's going to speak a little bit about more on. We have about 1,600 patients currently who have registered for that. So.
Talking a little bit about GPAC's accomplishments over the past few years, and starting with the patient registry. So GPAC was lucky enough back in 2015, in order to spur on the drive for treatments and cures in the conditions of gut paralysis. We were selected to be the sponsoring organization for the patient-centered drug development initiative developed by the FDA, where the FDA had recognized that there was a tremendous unmet need for the development of additional treatments for gastroparesis. And as part of that effort, we received grant funding to develop patient registry, sort of a sister registry to the current GP CRC with the NIH at this point, where we're happy to announce for some recent data collection that currently there are about 1,600 participants in the registry at this point, which we've done in conjunction with the Genetic Alliance. And some facts that we've just learned is that, in addition to that, of those 1,600, about 800 patients recently responded to comorbidities here at this point, and we're seeing comorbidities where approximately 10% of the individuals who've responded also have chronic intestinal pseudoobstruction, about 7.5% have colonic inertia, and about 29.2% have chronic idiopathic constipation. And so one of the challenges you see in these disorders affecting the entire digestive tract is that it's very important for clinicians to be able to separate out regional disorders of GI motility versus pan disorders of GI motility, to be able to figure out what treatments are most important, what drugs are most appropriate, what surgical procedures might be most appropriate. One of the challenges we see in terms of surgical procedures is to avoid what we would call railroad tracks, where patients have multiple surgeries for these conditions, eating away at nerve and muscle tissue and ending up in places where we don't want them to be, where conservative care becomes a very important element. We worked hard and with sister organizations located worldwide, including in Australia, and also we're proud of the Sister Pseudo-Obstruction Research Trust located in the United Kingdom, which has received done remarkable work. In 2001, we were lucky enough to be selected to receive grant support from Chase Bank, and we've received support and commendation for being one of the best nonprofits, and from GuideStar in the United States. And again, we've talked about the registry here at this point, and we're happy to provide, along with IFFPD's work as well in their recent report, that really enhances the amount of data out here, because in the 21st century, solutions for these conditions are going to be driven by data, and without data, that's how we're going to solve these conditions going forward. This is a little bit more about the registry, and we'd be happy to talk more to patients offline about it. We're in the process of putting together the data to come up with an interim research report, which we'll be happy to provide to patients when that is published in late 2017. So again, if you're a patient, please give your contact information to Chris or myself, or visit our website at g-pact.org. Moving on in terms of our advocacy efforts, like our sister organizations, IFFPD and the ANMS, we are also members of DDNC, which is a 501c4, which permits us to periodically advocate in Washington. Specifically, we participate in Hill Days, which now occur in December and March at this point. And, we've been, quite active and adamant in those efforts, and we participate with our sister organizations. Much like IFFPD, we are very much supportive of what we nicknamed FIGIMID HR 1187, and we feel very strongly here at this point. We're in New York that does a tremendous job of funding applied medical research, but government really needs to spur and develop basic research so that folks like the Doctors Hamilton can do the basic work necessary to then apply for treatments here at this point. We're also proud of the fact, quite recently at this point, one of our very active patients, the young Andrew Bellevue, has been a real inspiration in sort of our version of the Ice Bucket Challenge, or Pie Face Challenge, and he managed to get most of the members of the Boston Red Sox, which is a New York Yankee fan, is a tough nut to swallow with us up to Jill Stas and participate in the Pie Face, but we are really thankful for the Red Sox effort, and Andrew's efforts quite recently were covered nationally on ESPN, and we're very proud of his efforts, along with the efforts of young Sarah Gebert, who one of our patients in the tri-state area, who fought back against pseudo-obstruction in the PICC line and was just received a college scholarship to be an NCAA softball pitcher, and we're very proud of her as well in her efforts. From a policy standpoint, GPAC has adamantly fought for, I don't know how many in the audience have dealt with issues relating to GP or pseudo-obstruction, but one of our real challenges goes beyond just a medical challenge. Quite frankly, it's a legal and policy challenge. We realized and discussed, during our sessions on three important GI prokinetic agents, peridone, Zelnorm, and cisapride, and for reasons that would be too numerous to discuss in this short setting, they are subject to what we call the FDA individual directive process, and patients, including myself, needed to take several months and lots of time and effort in order to gain access to these drugs, which either had been withdrawn or had been not approved in the United States, however, are available quite extensively in the United States. We are part of an initiative called the Right to Try Initiative, where we greatly respect the work of the Food and Drug Administration in protecting the safety of our food and drug supply and the efficacy of those foods and drugs, but where our researchers have sort of proven and shown light the way here at this point of the viability of these agents in the treatment of our patients. We hope to ease the process of our patients to gain access to these medications at this point through both the Right to Try initiative and also the development of an Office of Patient Advocacy within the FDA, which would bring about the notion of guides who can sort of navigate patients through the FDA's processes in these areas. And we're proud to report that earlier this week, by a vote of 100 to 0, the United States Senate agreed with our efforts, approved a bill which will now be going to the House of Representatives and hopefully and eventually to the President for signature and execution here at this point. And so we continue on those efforts, and we're going to continue on that fight until patients get what they need. In addition, a few other points. To spur that initiative, we sponsored a forum in New York City back in February 2016 with some policy experts, including the Manhattan Institute here at this point, to discuss some of these concerns. Also, in other areas of vital interest and advocacy in these areas, we've partnered with a remarkable patient by the name of Lynn Wolfson, who's a real leader in the ostomy community, in an effort to make public restrooms, particularly subject to the ADA, more accommodating to folks who have to carry around IV nutritional supplies or who have other specific needs that can be fairly cumbersome in terms of being able to maintain their ability to travel and an attempt to maintain normal lives and their dignity. The other area we feel quite strongly about, there have been a lot of problems with recent shortages of the substances that make up TPN and other infusion medications. And one of the things that really concerns us, we hear about shortages of vitamins and minerals that are necessary for proper nutrition under TPN at this point. And then we see like infusion or IV bans that detract from those supplies. We work with our sister organizations like ALDI to preserve the viability. One final point, and just to conclude here at this point, Ken worked with him as well. We just wanted to lend tribute to Dr. Martin Schuster. Martin Schuster was one of the real foundational leaders in neurogastroenterology. A lot of us would not be here. I know physically I would not be here without him at this point. He was my physician. Dr. Schuster was the past president of the American College of Gastroenterology, and along with Dr. Cook, was the lead author of the Schuster Atlas of GI Motility, which was really the foundational area in this. Dr. Schuster was a very kind human being. He was both expert in the science and healing art of medicine at this point, and his work has led to the training and the development of the next generation of neurogastroenterologists, and we follow his example. And just leave Chris to conclude.
Just want to say, that this is the digestive tract paralysis awareness month, which includes gastroparesis, chronic intestinal pseudoobstruction, colic inertia, other paralytic conditions of the digestive tract, and feel free to grab our booth and talk to us and get involved because that's really important. Any patient can do it, so there's our contact information.
And we'd like to thank Dr. Katz and the ANMS for having us, and thank you.
Great. Thank you very much to all the speakers, all 7 speakers. Would you mind joining me actually at the front? So this is really the opportunity for all of you to ask the questions you've been holding in for the last 75 minutes or so. So we'll actually take about 15 minutes of questions, and I will actually be repeating the questions, so you can say them. I will repeat them as we're actually going on Facebook Live right now. So we actually have a lot more people actually viewing than in this room. So please just raise your hand, or you can stand up. Yes?
I have a question about the pain of IBS and why it seems to be so difficult to treat the pain. It feels like a different kind of pain than other. If you take a Tylenol for something, it might work pretty easy for pain. But IBS just seems to be a thing that the pain is really difficult to treat. That's my...
I'm going to try and address that.
Okay.
The way to think about IBS pain is that the insides are more sensitive. So you're actually feeling normal happenings on the inside. Whereas the pains that medicines like Tylenol or Motrin help are integumental or musculoskeletal pain, where there is a specific reason that is triggering the pain. The
pain of IBS is related to normal happenings because the insides are more sensitive. One way to think about this is the volume control in your car being a little too loud and it's uncomfortable. So the volume control of perception of sensation is a little high on the insides. That's why treating this IBS type pain involves using agents that alter how the nerves talk to each other, using other therapies to alter how the brain perceives these sensations, and reducing triggers in the intestine that are bringing about some of these discomforts.
And if I could just add, speaking less from IBS but general with motility pain, and having been a patient for 30 years with this, one of the challenges in the treatment of pain is that unfortunately a number of the agents that we currently have the concomitant factor of sometimes slowing down and knocking out motility at this point. And the challenge is to balance out using just enough of the agent to really preserve motility so you don't develop and end up having a vicious cycle where you initially treat the pain but then knock out the motility and repeat the cycle, as it were. That's why the work of folks like Dr. Kiefer as well is important at this point in terms of complementary modalities until we develop, say, a next generation of medications where other modalities like acupuncture and biofeedback might be helpful, at least in terms of the short term, dealing while we work to develop additional and better pharmaceutical agents at this point.
Okay, anyone else? Yes, please.
There was a mention of cognitive behavioral therapy. That there's a clinical trial that was going on. I can't remember who else.
Is Dr. Kiefer here? Lori, you want to
Yeah, sure. So we just finished, myself and Jeff Lackner, who is the principal investigator at SUNY Buffalo. We just finished a 9-year trial with about 460 patients who participated in one of 3 treatments. It was a randomized controlled trial, and we basically randomized patients to either what we sort of consider the gold standard cognitive behavior therapy, 10 sessions, right? Once a week, come see your therapist. You really kind of you'll learn all the different skills that are important. Or you could be randomized to a minimal therapist contact version of that. Because one of the main complaints that we get from patients is I just can't either afford it, or I can't take the time off work, or I can't get to, the doctor's office is too far away. I can't drive 3 hours every week for the appointment. So we tested that with a shorter, faster, better, cheaper intervention. And then there was a control group. That was an educational control group. It was a nice group. Some patients benefited from it. The interesting thing that we found out was that actually the minimal contact was just as good as the long, drawn-out one. And we're still looking to see if we can dig deeper and figure out for which patient. So some people might need the full 10. Some people might be able to do it with the 4. But it's actually really exciting. I can give you the main principles are that differ from other forms of cognitive behavior therapy are that we really target the GI tract. We target that stress sensitivity. We target the thoughts around things that people tend to do when they have IBS, like overestimate the likelihood that they're going to have a bowel accident, overestimate the likelihood that they're going to have pain after eating. So we kind of really work with them on that. We work with them on decatastrophizing. So what happens after you have had a symptom exacerbation? Can you handle it? How are you going to handle it? What are you really going to do? When I was in Chicago, we used to talk about people driving on Lakeshore Drive where there were no bathrooms other than porta potties, right? And it was everyone's fear that they were going to have to go to the bathroom when they were on Lakeshore Drive. And so that was the kind of thing that we would focus on. And then lastly, really modifying arousal, reducing your through diaphragmatic breathing, and we had a little bit of teaching of our faculty yesterday around doing that. But it's I would highly recommend the intervention, and now that we can do it in a shorter form, I think it's a lot more accessible for you guys.
Okay, thank you very much, Dr. Kiefer. Yeah, we have another question.
Hi,
So I have abdominal phrenic dyssynergia, which is a functional GI disorder that no doctor in America seems to know about or treat. And I've been really frustrated over the last 6 years trying to get care. I've had to actually leave the country to find a doctor that treats it. And I want to know, like, what can we do in America to raise awareness amongst doctors, whether it's through like increased funding for research or treatments. Like, I really want to get involved. Like, I want to be an advocate. I am still dealing with this every day. I'm like about to cry because this has been the focus of my life for so many years, and I'm so mad I need that better, and no one seems to really know about it. So I just want to know, like, what can be done? I'm really encouraged to and passionate about this. Like, I'm willing to advocate to Congress for the bills and everything. I want to get involved, but what else can be done?
Is any patient support?
Yeah, the thought, and I'm not familiar with phrenic dyssynergia, but it's, to give you context, when Chris and I were dealing with the situations really over the course of the past 30 years, when we first started dealing with pseudo-obstruction, there was nothing, or next to nothing in terms of awareness and advocacy, and it still remains somewhat of a challenge. I mean, we sometimes say, we've felt at times that we're like about 20 years behind Crohn's disease, for example, but what we've seen, and I'm a little more of the academic here, so I'll talk about the marginal benefit here at this point. What has changed readily in the past 30 or 40 years, and dealing with my cousins, and I have a very outspoken, older aunt who says, Mike, your biggest problem is you don't know how to go, caca, and the rest of the world can't deal with it here at this point. There's been a sea change in mentality here at this point over the last couple of years, and where that sea change is that the digestive tract, to be perfectly honest and blunt, had formerly been regarded as the garbage disposal of the human body, and the revolution that we're seeing very early starting to see take place, our friends at IFFBD are seeing this as well, at this point is a revolution in understanding, as Dr. Hamilton understands with regard to Parkinson's disease, just how important and vital the function of the digestive tract is to the rest of the body. The digestive tract is the entrance hall for the body. It's the entrance hall for the immune system. We're beginning to see foundations in which chronic neurologic disease may initially start up in the gut and then spread up through the nervous system. There are some theories on that at this point. We may very well be at the start of a revolutionary time in gastroenterology, where even something like, for example, in New York, and I'll close on this note, the concept of fecal transplant that even my dad who's dealt with me for 30 years on these conditions and left at this point, the concept that something like that can significantly change the microbiome of the gut and tremendously improve and change the outcomes of chronic GI disease. We are rethinking substantially how we think about these disorders. The problem is sometimes you don't see a revolution until you realize you'll go through it at this point. And I would just tell you to not give up hope. The internet has exploded here. Knowledge is starting to explode at this point. There are 300 million people in this country, and you're going to find people who are going to begin to have interest in the marginal difference that you can make. Unlike cancer, where there are not to pejorative against cancer, there are a million cancer experts. You alone can change the world for about, probably hundreds of thousands of other people who may very well have this disorder and just sit home silent and frustrated. Your act of coming here might be the impetus to get on a roll here at this point. So that's my thought. Keep on. There's a saying from Winston Churchill that when you're walking through hell, keep on going, because the alternative kind of sucks.
Okay, any other questions? And I'll remind you, when we're done with the question and answer session here, we're actually going to be breaking out into rooms where you can meet a local practitioner in the area of your choosing. Any other questions?
I have another question about, I think it was Dr. Hamilton, the elder. Regenerative medicine, can you speak a little bit more?
Yeah, what our division has been doing, and we've launched some activities looking at using stem cell biology, looking at possibly as an alternative approach. It's very, very in its infancy because of the great congressional concern about using stem cell research. There was a hiatus, or I should say a moratorium, of really pursuing stem cell research at the NIH. So we were sort of halted and asked not to proceed any further, but I think things are going to be moving in the right direction, looking at properly stem cell transplantation in the setting of IBS and other conditions. but we're still very much in the infancy at this time.
Good thing to follow.
Yes.
Hi guys. So for the past few years, I've been dealing with gastroparesis and colonic dysmotility and POT syndrome. And I found that since I returned from Mayo Clinic, I've been on a variety of different medications, and it seems like the side effects of a lot of my meds often outweigh the benefits. And I've talked to other patients who deal with what I have, and they often say, you know, the best time, when I felt the best, I was actually off of all of my medications. But it's hard because when you go through every day feeling horrible, all you want to do is find that quick, easy fix and take something. But I'm wondering, for those of you who've treated patients, if you find that the less meds, the better often, if that's a case, and how can you measure when to take more, or when the side effects do outweigh the benefits, or vice versa? And then my other question is, with domperidone specifically, if you guys have ever encountered women lactating a lot on that drug.
Is Ken Cook in the audience? Ken Cook is one of our investigators on the NIDDK gastroparesis, and he has been really sort of at the forefront of seeing patients with gastroparesis. Do you want to address her concern about the different medications that we've attempted to use in the setting?
Yeah, so thank you for sharing.
Can you come up so loud? Can you use the microphone? Didn't want to put you on the spot.
No, it's just, thank you. It's just, important that we hear people's stories, because we hear them all the time, but this is a public group, so thank you. So number one, I think one thing patients should do is tell the doctor about what is the number one symptom. You can have so many. And I always ask, what's number one? What's number one? What's number one? Okay, I'll take number two now and then, but what's number one of the symptoms? And then how do we investigate that? And then are there drugs to treat that particular symptom? So we're trying to find out what's driving that symptom. And then I'm afraid, I often tell my patients there's very few drugs. So why don't we stop a few? I absolutely do what you've done. I said, let's stop a few. Maybe patients somehow get on to 10. I said, how many of these can we reduce, especially narcotics? So that's very important. So I think that's good. And then I find myself, because of the paucity of therapies, talking a lot about diet, hydration, and with POTS, it's doubly important. So it's a bad combo you have. And but we do try to divide and conquer and stick with kind of the minimum that will allow you to get through the day, and hoping for better drugs, maybe just a better understanding of the pathophysiology of those diseases. So, that's my sort of brief clinical overview. Did that get at some of your...
Yeah, and the domperidone specifically?
The domperidone story, yes, about 5% of women do have, lactation that's just is not tolerable, really. There can be different grades of that, and there's not really a way around that I know. So you kind of have to come off of it if it's a big problem. I think there's an interesting side bit, though, that that drug elevates prolactin. It's one of the things it does, and some people think the higher the prolactin, the better the drug effect. And prolactin is a very good hormone for well-being and making you want to eat, and it's wonderful for breastfeeding mothers. It drives that whole scenario. So it's interesting that drug raises it, but for some people it's not tolerable, and the only thing to do is come off of it.
Just as a patient, with this, and just add a brief thought in terms of the medicine combos. Two thoughts. Ken expressed this thought during the conference. One of the challenges with motility drugs we often enter into is a situation called tachyphylaxis, where our bodies build up tolerance to certain levels of the drug, and we ultimately need some sort of drug holiday. The other thing I would mention, because I have blood pressure issues as well from autonomic nervous system, fluid balance is very important. It's very important to keep an eye on medications that adjust your fluid balance or tend to play out. So Benadryl is sometimes one of the drugs that's necessary, and it's important not to go overboard on that. And I constantly walk around with bottles of fluid with me, particularly over the summer, because if your fluid balance is not right in these conditions, your muscles tend tend to lock up, you get dizziness, and that exasperates the POTS. So sometimes fluid balance is almost just as important as any medication you take.
Okay, so please give a round of applause to all of those speakers. Thank you very much. So now we're actually only going to split into 2 rooms. So those of you that are going to stay here are really the patients interested in hearing about gastroparesis, stomach problems, and nausea, vomiting, as well as GERD, chest pain, and swallowing problems. Those of you that will go down the hall to the left, to the Midtown Suite, will be the group for IBS, constipation, and fecal incontinence. And joining me up here in the practitioner groups for the upper GI group will be Dr. Bonnie Rowland, Dr. Il Pike, who will represent the gastroparesis, stomach problems, nausea, vomiting, and Dr. Michael Smith, another Michael Smith, believe it or not, will be coming up and joining us here to represent the esophagus.